and good evening for our colleagues from United States of America, dear Ruth and Brandon. This first session will be about obstetric anesthesia. In the past decades, we have seen many improvements in this field. We plan to have 3 distinguished faculty in this field: Ruth Landau, Brendan Carvalho from United States, and Mauricio Vasco from Colombia. Unfortunately, this morning we have news from him that he was unable to join us due to the family emergency. However, I believe we still have a great session. I invite all participants to give a comment and question so we can have a plenty of discussion. So without further ado, I would like to invite Professor Ruth Landau to give her talk entitled of Pain During Cesarean Delivery. Ruth, please.
Good morning or good evening for me, actually. I am in New York and it is 8 p.m. So I'm delighted. Cecilo, thank you so much for this invitation. I can't wait to actually be in Indonesia again. There's no such thing as a meeting that is virtual. It doesn't come to a full panel of what Indonesia has to offer us. But I so appreciate the invitation. And I decided to talk about a painful topic, pun intended. Pain during cesarean delivery is the thing we don't want to talk about. And I have decided that after many years of ignoring this event, it's about time that we talk about it. So I hope to share with you how to avoid it. And if we didn't, what should we do next? So the agenda for today is to prevent this event, obviously. If we didn't prevent it, how can we recognize it? How should we manage it? And how should we follow up on the women who unfortunately experienced pain during cesarean section? So I just wanted to show the magnitude of the problem, potentially. Cesarean section, we all know, is the most frequently performed inpatient surgery in the world, and it's not going away. And we can see here on this graph, it's recent statistics. It was published in The Lancet, which countries conduct the most cesarean section. It's in the Dominican Republic, followed by Brazil, actually equally common in Egypt. And I won't go through all the countries. In the United States, it's 33%. And in Indonesia, I believe it's also in these numbers. What that means that 85,000 women every day around the world are having a C-section. What that also means is that during our panel now, there will be there will be a lot of women having a C-section, and some of them might experience pain. So definitely an important topic to cover. And it's not going away, even though there are goals to reduce the cesarean section rates. These are the predictions. You have the QR code here on the right-hand side of my slides. If you approach your smart devices, you can actually download the references, and you'll find these on several of my slides. So the C-section rate worldwide in 2030 will be higher than now. It's going to be 28.5%, which means 1,110 daily. So right now it's 85,000. It's going up. It also means that between the sub-Saharan Africa, where the percentage is 7.1%, and Eastern Asia, with 63.4%, Indonesia is somewhere in the middle there. So here is where I work. I work in New York, in the northern part of Manhattan. You can see here, this is our labor floor. We're overlooking the George W. Bridge. And we are the Columbia University Medical Center. I'm proud to say that we are the recipient of the Center of Excellence designation, which is a recognition from the Society for Obstetric Anesthesia and Perinatology. I'm sure that Dr. Carvalho will talk about it definitely in his presentation. But this is our practice. We cover 2 campuses. We have 7,000 deliveries. Our neuraxial labor analgesia rate is pretty high. Most of our if not all of our procedures are actually combined spinal epidurals. And our cesarean section rate is in the order of 38% right now, with a very low general anesthesia rate, which means that 97% of our patients come into the operating room with a neuraxial anesthetic, either an epidural that was placed during labor that gets activated for the intrapartum cesarean delivery, or they get a spinal anesthetic in the operating room, or maybe a combined spinal anesthetic if there's an indication for a combined spinal over a spinal anesthetic. The focus of our interest at Columbia, in great part because this is the focus of my interest, is stepwise, opioid-sparing, multimodal analgesia. It's a lot of words, but what that means is that because there's an opioid crisis in the United States with too many patients being prescribed opioids as pills when they go home after their C-section, and because too many of them are taking too much opioids, we've really tried to have multimodal opioid sparing strategies so that women don't take any opioids. And I know this is not a problem in Indonesia, but it's certainly a problem in the United States and in North America. We're also really promoting enhanced recovery after cesarean delivery. And I know that, Susilo, you've been a fantastic spokesperson in Indonesia and made tremendous progress towards this goal. And I won't talk about it because this is Dr. Cavallo's topic. So I knew you would ask me, what's the cocktail that we use at Columbia? So I'll put it out there right away so you won't have to ask me what it is that we give in our spinal. And I'll also tell you what it is that we give in our epidural for those who came with an epidural into the operating room. So the cocktail that we use in a spinal, and we use a pencil point atraumatic 25 gauge needle to reduce the likelihood of post-dural puncture headache. And we give a mixture of several things. We have hyperbaric bupivacaine, and in the United States, the concentration is 0.75%, which is probably not what you use in Indonesia. But with that cocktail, we give 12 milligrams, and we add to it fentanyl, 15 micrograms, so that there is immediate analgesia that is provided by the opioid that is lipophilic, and we add to it morphine, which is preservative-free, and the dose that we give is 150 microgram, which might be higher than what Brendan might be presenting as the recipe that is used at Stanford. But the reality is that I put here a standard dose, but sometimes we give less and sometimes we give more based on the patient. So we do have some individualization based on the previous experience of our patients. But this is the standard approach. And sometimes we add clonidine, which is something that we've been using more and more to avoid visceral pain. And this is quite essential to the topic of today because clonidine has been shown to reduce the likelihood of feeling the pulling and the tugging. And because in the United States, a lot of obstetricians exteriorize the uterus in order to do the repair, this exteriorization results in much more visceral pain. And so the clonidine is very useful in that circumstance. But I put it in parentheses because not everybody gets it. And then if we have a patient who comes to the operating room with an epidural, and so it's an intrapartum C-section, this is what we give. So lidocaine 2% with epinephrine, it comes mixed with the lidocaine, which allows the prolongation of the lidocaine because it reduces its systemic absorption. And we add to it bicarbonate because it reduces the onset of action. And while this is controversial, because we have access to it and we prepare it really fast, or sometimes we have it even readily mixed, it actually does work in reducing the onset of action. We add fentanyl and we add morphine. And again, the doses here are sort of standard, but we do give sometimes less and sometimes more. And we also give clonidine, which has also, I didn't mention it, a very good effect in preventing shivering, which is something that a lot of patients complain about. So this is the cocktail that we use at my institution. Now, I wanted to show this slide, and you have here the QR code. The International Association for the Study of Pain had a definition in 1979 of what constitutes pain, which was the unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. But the definition was updated, and it changed into actually saying that it is sensory, it might be emotional. The word emotional was already there before, but it can be resembling that associated with actual or potential tissue damage. And what is important here is that pain is a personal experience. And so if a patient tells you that they experience pain, it's very difficult for us to say, no, it's not pain. It's just pulling. It's just tugging. It is a personal experience. It's influenced to varying degrees by biological, psychological, and social factors. And definitely women who arrive to the operating room for a cesarean delivery are going to be stressed, are going to be fatigued if they've been in labor, and might not have wanted to have a cesarean delivery based on their preference. And so all this needs to be taken into account. And so the new definition really emphasizes that pain and nociception are different phenomena. So what is the true prevalence of breakthrough pain during cesarean section? And I put here a question mark. It is a question, and I don't think we have the answer. Because as I just mentioned, someone's pain is not my pain. And what a patient experiences, which we often say, it's not pain, it's just pulling, it's just pressure, is really not quantifiable. So I went to a source that I believe it's a very important source. You'll see what it is. I went to see in not my favorite magazine, but one of those that I see often lying in waiting rooms, Cosmopolitan. And there are many, many, many reports of patients. Here, this is actually not that recent, from 2016, what having a C-section really feels like, according to 18 moms. And I'm sparing you all the descriptions because it's not particularly interesting, but you can see here, one of them said, it feels like you have no control of your body from the ribs down, but you feel lots of pressure and tugging. You want to move your legs, but you can't. The worst part is after the baby's out and you're just laying there helpless while the doctors literally put your insides back together before stitching you up. So did Jennifer feel pain? I don't know. She doesn't tell us here, but it doesn't seem like a very comfortable situation. So we're still sort of struggling to know what is the definition, but this is what we're seeing more and more in many publications. So it's two things. First is the inability to achieve the desired sensory level of anesthesia. So this is something that we can measure. This is what we do when we test the sensory block, the anesthetic block. The second definition is breakthrough pain and poor maternal satisfaction. It's the mother telling you that she's in pain, or she doesn't tell you that she's in pain, but she's saying, ow, ow, I, and is not comfortable. And then there are other ways for us to decide that a patient must have had pain if you look into their medical record and you see that there was a repeated neuraxial anesthetic. And I put here in parentheses, need to repeat a planned neuraxial anesthetic, because we never know whether it was necessary. We just know that it was done. So we assume that either the block wasn't good or the patient was in pain or something happened with the block. And clearly there was inadequate neuraxial anesthesia. So this is a measurable or a quantifiable and something that can be found in the medical record. You can also find, if the patient has an epidural, that there was additional drug either before the skin incision or after the skin incision that shouldn't typically have been given the timeline. But you can assume that the patient must have experienced pain for the anesthesiologist to have decided to give additional medication. Definitely, if you start seeing medicines, adjuvants, such as fentanyl, such as ketamine, or other analgesic medication, which are not usually given. So unplanned administration of IV adjuvants would definitely qualify as being an intervention that was undertaken for inadequate neuraxial anesthesia. And obviously the conversion to general anesthesia for pain, not because the patient bled or not because there was another reason. So these are all things that one can find in medical records or one can find in studies that reports pain during C-section. So we have this excellent systematic review that is published right now. It was very convenient for the preparation of my presentation, and you might recognize names here, but definitely Brendan is aware of some of these authors because Pervez Sultan, who's the last author, is a member from the Stanford Obstetric Anesthesia team. So this is a systematic review that was very smartly done, we're not surprised, to estimate the prevalence of inadequate neuraxial anesthesia in planned cesarean deliveries under neuraxial anesthesia. And I bolded here the word elective, because under an elective C-section, the component of emergency or time or having to rush and having an epidural not have the time to kick in or having a spinal not work is obviously removed. So this is an important study, but it still doesn't reflect on the actual incidence, because more than half of cesarean sections that are done in the world are actually not elective. But what they did in this study is that they pulled out all the randomized controlled trial that compared two anesthetic modalities that were utilizing more than the ED95 or what is accepted for the neuraxial anesthetic. They identified over 2,100 studies and included 54 studies. In those 54 studies, there were 3,497 patients. So why were only 54 studies included? It's because they looked at quality of studies. They ensured that there was the reports of who didn't have sufficient anesthesia when it would have been expected that they would have had a sufficient level because the ED95 was given. So these were not dose response studies, but really studies where the dose of anesthesia would have been expected to provide sufficient anesthesia. And they found that such supplemental analgesia or anesthesia was given to 14.6 patients of the patients, which was either intravenous medication or nitrous oxide. So again, it's a number, it's 1 in 6 patients that have a planned cesarean delivery, not urgent, not emergent. And the general anesthesia conversion rate was 1 in 1,750 or 0.06%. Another important thing, which we already know from previous study, but it's confirmed again, is that if the anesthetic was a spinal or a spinal as part of a combined spinal anesthetic, it is associated with a lower prevalence of inadequate anesthesia. It's only 10% versus 30% of epidural anesthetics. So important numbers, but still it doesn't cover the whole spectrum of cesarean deliveries that we perform in our clinical practice. And here I want to present an important paper that was published a while ago, and David Bogot, whom you all know very well, he's a dear friend, actually presented this topic, I believe it was 2-3 years ago, about pain during C-section and how it is a cause for litigation, because in the UK, this has been a topic of interest, and there have been publications looking at litigation. In other words, when patients experience pain and decided to sue the anesthesiologist or the hospital or both. But this is a human story. This is not a lawsuit. This is a patient, you can see her on the right-hand side, Susanna Stanford, who is a patient who had first an unplanned cesarean delivery under an epidural anesthetic, and it worked great. There was no pain, despite the fact that it wasn't a planned C-section and it was an epidural, she did not experience pain. And when she came for her second cesarean delivery and she was having a spinal anesthetic, and she met the anesthesiologist and really didn't expect to experience pain because she was told the spinal will work and it worked last time, so this time will work as well. It should even work better. She actually experienced pain, and because she experienced the pain and she didn't, I'll back off for a second. Before she experienced pain, the spinal was done and it was tested by the anesthesiologist, and she wasn't quite sure what she was feeling with the testing. She didn't know what she was supposed to expect, what she was supposed to feel. And instead of saying, I'm not sure what I'm feeling, and I actually think that I'm feeling everything you're doing, she trusted the anesthesiologist and didn't want to come across as being complaining. And she said it's fine, when in fact she knew that it wasn't. So they started the C-section, she experienced pain, and then was put to sleep. And so as she reports, there was nothing that was done wrongly by the anesthesiologist, because he tested, but she didn't say she felt pain. She then received a general anesthetic, which is considered what is necessary to do if a patient is in pain. But she decided to become a patient advocate. And in this paper, she is interviewed by David Bogot, and there are many interviews by her, and you have here the QR code for the paper. She talks about all the steps where she believes that improvements can be made. First of all, when meeting the anesthesiologist, the conversation could have been more detailed. After the testing had been done, the testing wasn't done in a way that she believed was very good. And then everything and her interpretation of the relationship between herself and the anesthesiologist, where she felt that she didn't feel comfortable complaining, and she thinks that women should be empowered to express what it is that they're experiencing. And it goes on and on and on. And even though she had the general anesthetic, she woke up and was traumatized by the experience. It took her months to recognize that she was traumatized and that she had postpartum depression. And she started seeking help for her traumatism. So I think it is worth reading, it is worth listening to, because it is illuminating, unfortunately, and there are probably many women who experience what she experienced that we're not even aware of. So the French group, or the CARO, we know some of the authors on this paper, decided to convene, and they have put together a French practice bulletin that is published in French on their website, but was translated into this document and published in Anesthesia, Critical Care, and Pain Medicine. And I was fortunate enough to be involved in its translation and in writing an editorial. I think this paper, you have to read it. It allows you to identify all the steps where improvements can be made. And you have here the QR code to be able to download the paper and my editorial. So they came up in their paper, and I think the important point is that they put together a task force of 30 people. There were anesthesiologists, obstetricians, neonatologists, midwives, nurses, patients, lawyers, psychologists, hospital administrators, and each one brought their perspective around the table. So they came up with a novel definition for what is insufficient or failed neuraxial anesthesia. It's any circumstance when under neuraxial anesthesia, the patient requests additional medication. So it's not the subjective decision of the team. It should be a joint decision. So essential to this definition is that anxiety and discomfort expressed by the patient must be taken into consideration, and they are as important as the objective testing of the surgical block before the surgery begins. So I'd like to come back one step backwards. How should we be testing the surgical block after a spinal or an epidural has been placed? And again, I put here the British flag because in the UK, this has been a big topic of controversy, with a lot of people disagreeing about what the modality should be. But the first paper that sort of came up with a proposed dermatomal level and also the sensation that should be used to test the block was published in 1995. And the idea was, should one test with pinprick, which reveals analgesia, or should we test with light touch, which tests for anesthesia? And in this paper that was published in 1995, what the authors did, they took over 200 cases of patients who had had a cesarean section. They looked at women who experienced pain. They looked at how these women had been tested. And what they noted is that in women who had been tested and had been found to have loss of sensation to light touch at T5, none of them experienced pain. Hence, this sensory modality has been adopted in the United Kingdom, or so you would think, but that is what is recommended. The problem is the following. There are two issues. The first one is, where is T5? So in a paper published, I can't remember in what year, but you can see here that there were 73 anesthetists that were asked to show with a little star, where is T5? And 66% of them identified correctly where T6 is, which means that 1/3 did not. You can see the stars all over the place. This is not T5. And then another thing, a survey that was done and published was how UK obstetric anesthetists assess neuraxial anesthesia for cesarean delivery. So despite having the papers and the recommendation to test to light touch, you can see that in 2004, most anesthetists were testing to cold actually at T4, and it increased in 2010. But people were not testing to light touch, or very few people were testing to light touch at T5. It's only 26% of the surveyed anesthesiologists. So even though this is the recommendation in the United Kingdom, it is not followed. So what should we remember about testing? So the dermatomal level is most cephalid using cold. So if you're using cold, you really need to be sure that the patients are not able to discriminate between cold and not cold at the highest possible level, definitely at T4, if not above. And that's due to the C fibers that conduct the cold sensation. If you're testing to pinprick, which require blockade of the A delta fibers, probably a T5 level might be okay. And if you're testing to touch, then definitely it should be, T5 seemed to be appropriate. I added here the vibrating phone icon because some have been advocating testing to the vibration sense, which is more resistant, and it's the vibration level is lower than the pinprick level. However, not all of us have vibrating devices. And so I think that you really have to use whatever it is that is available. But if you are using cold, you should be sure that patients are not able to discriminate at a relatively high level. Another thing that is important is that if you've had an indwelling epidural catheter that has been providing labor analgesia with an infusion or a programmed intermittent epidural bolus, women might have a level to cold, but it doesn't mean that they have the anesthesia. So it is important in those women who have an intrapartum epidural that is converted for anesthesia to test to pinprick and not to cold. So I'm coming back to the French practice bulletin. They identified 5 important areas or themes to work around. First of all, it's important to prevent. So it's important to have an appropriate neuraxial anesthesia and to test the surgical block prior to letting the obstetrician do the incision. It is important to communicate around the decision to delivery time. In other words, if it is a situation where there's an emergency, it is important to know if the block isn't working, is there time to repeat an neuraxial block? Is there time to re-inject the epidural catheter if it is believed that it is working, or simply to wait for the dosing that has occurred in the epidural catheter to have the time to kick in? So communication is essential to the decision of what needs to happen. And obviously appropriate management of pain will depend on whether it is identified that the patient has an insufficient block before the skin incision occurs, or if it is at the time of the skin incision, or maybe after the skin incision once the surgery is progressing, or if the obstetrician are exteriorizing the uterus, as happens quite often in our patients. And so we need to be ready to recognize it, and we have to have an action plan to manage the pain. And so another thing that is important is to have a mechanism to audit all these cases. So if there are interventions that are put in place, have a mechanism to audit the cases, and have the screening, the prevention, and the management of complications as something that is part of the follow-up of patients. In other words, if the patient did experience pain, or if the patient had a general anesthetic, it is important to go and assess the patient and debrief the situation to see if this patient is okay with it or is developing signs of depression, potentially postpartum depression. We know it is associated with acute pain and persistent pain. And definitely if there's signs of post-traumatic stress disorder. And finally, the management of the medical legal issues and the mitigation, which are going to be different based on the country where you practice. So a lot of things to do to prevent, a lot of things surrounding communication, a lot of things at the time if it does occur, and then what to do after if unfortunately the patient did experience pain. So the key steps are, as I mentioned, communicate with the patient and set expectations. I don't think we do a very good job in telling patients that they're going to feel things. And a lot of women say, I won't feel anything, right? And we don't tell them, you will be feeling things. It might be pulling, it might be tugging, it might be uncomfortable. And if it is the case, please let us know. But I think setting the expectation is essential. It is essential to check appropriately the surgical block before skin incision and to be ready to take action. It is essential to believe our patients. I hear my colleagues, and I'm sure I do it as well, where I tell the patient, no, it's no pain, it's just pressure and it's all good. It's so difficult to identify if it's just pressure pulling and tugging or whether it is actual pain. I must say I've recently in the last year started to really ask patients, would you like me to give you something? And surprisingly often when I'm thinking the patient is really uncomfortable and about to give something, the patient says, no, I'm actually okay. And I have even on certain circumstances told the patient, may I ask you then why you are so loud? And sometimes they say, oh, I'm fine. And I say that in a way so that the nurses and the obstetricians hear that, because they're on the other side of the curtain and sometimes they really think that the patient is in a lot of pain. I think it's important that everyone hears the patient say, I actually don't want anything, I'm okay. And if we feel that it is not okay, it is important to call for an intraoperative huddle with the obstetricians and make the decision. Are you almost closing? Are you able, if the uterus is exteriorized, to place the uterus back in? And if they say that they're not and they're not close to being done, then we will, after we've given anesthetic rescue options, if we've given medication, then we might put the patient to sleep. And we always have to have a rescue strategy, because obviously just telling the patient that it's pulling, tugging, and it's normal is not a solution. I already mentioned the documentation, the debrief, and put things in the medical record. It's important because these patients might come back for another cesarean delivery, and it's important to know what actually happened and what actually was given, because patients often don't know what happened and might tell you that they went to sleep when they didn't go to sleep, or vice versa. And as I mentioned, follow up the patients. So the French came up with this infographic, or this algorithm that delineates what to do if the patient has an elective or scheduled cesarean section. Obviously, in that circumstance, there's more time to fix the failing neuraxial anesthetic, potentially replace the neuraxial, repeat a spinal or a combined spinal. I will not discuss how much medication needs to give in a spinal or a combined spinal epidural after an epidural has been dosed, because this is an impossible question to answer, and obviously carries the risk of having a level that is too high. So we don't want to have a total spinal either. This is a topic in itself, and I don't have the time to discuss that now, but they do have here in the algorithm that if there is a partial failure from the first anesthetic, you should consider a combined spinal epidural with a lower spinal bupivacaine dose, just to avoid having too high a block, but also not having a second block that is not sufficient. The epidural catheter will allow redosing. And you can add neuraxial medication if you have the time. You can give more local anesthetics. We often give clonidine, even if the patient hasn't complained of pain, but we like it as an adjuvant. And if it's a spinal and you don't have the opportunity to give more medicine, or you don't have the time, or it's in the middle of the case and you can't reposition the patient to have access to their back, there are a lot of adjuvants that can be given. So in France, they're proposing or suggesting alfentanil or remifentanil, ketamine, and propofol. That is not exactly what we use. We tend to give fentanyl or morphine. We would give midazolam, which is not at all in the suggestions that the French practice bulletin had. We do like to give doses of ketamine, but we wouldn't give ketamine without giving midazolam to avoid the dysphoric effects. I would not give propofol IV. I think that if you're starting to give propofol, you have to start thinking about securing the airway, and that starts to look like a general anesthetic to me. But I have recently started to give dexmedetomidine intravenously at doses of 15 microgram. That has been reported in case series. It also has been reported as a great adjuvant to reduce the shivering. And because it's given intravenously, you don't have to worry about whether it's preservative free or not. So we've started to give it, and patients feel great with it. And if your patient doesn't feel great with anything you're giving, then obviously induce a general anesthetic. and do a rapid sequence induction or modified rapid sequence induction, and let your obstetricians know so that they are aware that you are inducing general anesthesia. So my final remarks are the following. Prevent, recognize, manage, and follow up. And unlike what happens in Las Vegas, what happens in the operating room doesn't stay in the operating room. If you've had acute pain during cesarean section, it will be associated with persistent pain, postpartum depression, post-traumatic stress disorder, or a traumatic birth, and you need to follow up with the patient. You can't just say what you felt in the OR was normal. It's not normal, and it causes long-term sequela if it's not treated or considered or even acknowledged. What Susanna Stanford said was she didn't feel validated. What she had felt in the operating room was ignored and brushed off, and that was what was causing her to feel traumatized. So I'd like to invite you, if you're interested, the Society for Obstetric Anesthesia and Perinatology, SOAP, has now special interest groups. You do need to be a SOAP member to join these special interest groups, but there's one that is particularly dedicated to maternal mental health and birth trauma, and pain during C-section is definitely a topic we're discussing in this special interest group. So I invite you to join us if you're interested. And I'm also inviting you to join us at our annual meeting in Chicago in May. It is hopefully going to be in person, but I pretty much think it will be in person. So I hope you can join us. We will be talking about maternal and neonatal healthcare inequities. Thank you very much.
Okay, Ruth, thank you very much. The take-home message: never ignore patient complaint about pain. Prevent, recognize, manage, and follow up. It's very easy to say, but we are get used to do like business as usual. Yeah. So thank you for reminding us for this. I think I always teach my resident. Don't forget the patient satisfaction is only 2 or 3 pain, if not pain, if no nausea and vomiting, and now enhanced recovery. So it's time for now to Professor Brendan Carvalho to give enhanced recovery after C-section, and then you may answer the Q&A box, or you can wait after we are doing all the presentation. Thank you, Ruth. Yes, please, Brendan.
Well, good morning, Indonesia. It's, as Ruth said, evening for us in the United States. I'm on the West Coast, the better coast. And it's an absolute pleasure to be participating. And as Ruth mentioned, I wish it could be in person rather, but in these crazy times, we have to change how we administer medical education. So today I'm going to be talking to you about enhanced recovery after cesarean delivery. I know it's an important topic, and Cecilia has told me there's a lot of interest and activity in trying to move towards enhanced recovery. So I hope this is useful to you. Obviously, I work in a different institution in the United States, a heavily well-resourced area. But a lot of the lessons I think are very pertinent to any clinical practice. Now, what we learned with COVID is that people generally continue to have babies, and it hasn't really impacted births at our institution. In fact, if anything, since COVID's starting to go down, we are starting to notice more births. And as Ruth mentioned, almost a third of cesarean deliveries are by cesarean delivery. So it's millions of women who are affected by the surgery. It's the most common inpatient surgery. And therefore, it's really important that we do a good job, because we're affecting a lot of women, and they have a good reason to have to recover quickly and look after their baby. Now, the SOAP Centers of Excellence, which Ruth mentioned, is a SOAP initiative to recognize institutions that practice excellence in obstetric care, and I encourage centers to apply. There's many centers worldwide who have fulfilled the requirements. But under the cesarean delivery criteria, the #1 criteria starts off with insisting that institutions offer enhanced recovery after cesarean delivery. And it's defined as a standardized protocol or pathway that is utilized, and that it is an essential element that if without offering this, you will not be a center of excellence. So it's very important that this aspect of care is recognized. So my talk's going to cover certain areas. I really just want to basically define what enhanced recovery is. There's a lot of confusion what it really means. I go through what elements of an enhanced recovery or ERAC protocol would constitute, try and provide you some evidence whether or not it actually works, how to measure success, and then a little bit on implementation, which is often the tricky part. Now, I've been around for a while, so I remember the practice, which was very much allowing each clinician to do whatever they wanted, no standardization of care. So it depended what day you delivered. Care was completely different by surgeons, by anesthesiologists, and sometimes it was excellent care, but the lack of standardization was problematic, and it led to huge variability in how patients were cared for. So a while back now, a colorectal surgeon called Hendrik Kenlet decided, actually, we should be focusing more on recovery and not just doing surgery. And for colorectal surgeon moved towards minimally invasive surgery. But the initial attempt at enhanced recovery protocol was really just providing good analgesia with epidurals and early feeding to allow return back to function and particular bowel function. So this gave birth to the concept of enhanced recovery. So what exactly is it? Well, essentially, it's just standardizing care with the main aim to reduce variability. So you want everyone to get this care, and you want it to be multidisciplinary. You want all key stakeholders involved in care to be around the table, using the best evidence we have to create protocols. And then this needs to be continuously evaluated, improved, enhanced, and changed based on of feedback, and as well as changing evidence for what works and what doesn't work. So if you apply this, you will able to improve the quality of care you do, improve outcomes, and at a reduced cost. This is the supposed triple aims that's been proposed, where population health can be looked after better and the entire experience improved without necessarily increasing cost. So this is the aim behind it. Now, a lot of you are familiar with how this works in other surgical models. You start before surgery with preparation, pre-op, intra-op, post-op, and then discharge to return back. And this is an example of an important publication looking at various aspects, both with surgical changes, anesthetic changes, as well as nursing changes. But obviously, cesarean delivery is an entirely different model, and we acknowledge this. So this is an infographic from a review article that we wrote. And I think what makes the cesarean delivery surgical model so unique is that you arrive in hospital with one person and you leave with two. So the idea behind this surgery is extremely different to a normal surgery. And recovery is essential because you are expected as a woman to look after your newborn at the same time as recovering from surgery. So the stakes are even higher that we optimize recovery. So this infographic runs through that same continuum that you see in other surgical models, moving from pre-op into the operating room to PACU to the maternity and then home. And we'll be going through a lot of these steps as we discuss more in this talk. Now, if you're going to take one photograph of the slide that I'm presenting, this is it. This is all the data we have for enhanced recovery. It comes from a very important consensus statement that SOAP produced last year. Ruth was on the committee that came up with these consensus statements. And it was an important document because not only did it try and define enhanced recovery, but it gives very good recommendations and suggestions on how you can actually improve your practice. So it's an extremely practical document. The other enhanced recovery after cesarean documents that is essential reading is produced from the Enhanced Recovery After Cesarean, or ERA Society. And they do it in part 1, 2, and 3. Part 1 being the pre-op, part 2 intra-op, and part 3 post-op. But I'm going to focus mainly on the SOAP criteria and go through that going forward now. So let's discuss the elements of ERAC that SOAP's committee and the consensus statement came up with. So going back to the phases, pre-op, intra-op, and post-op, similar to what we used to with other surgical models, you can see a QR code in the corner if you want to get access to this important document. It came up with 25 interventions. You have 5 for pre-op, you have 9 for intra-op, and 11 for post-op. And we'll run through these briefly. Obviously, a short talk like this cannot do justice. Often, some of these criteria are talks in themselves. So just give you a flavor of what's being covered and what's being expected. So starting off with pre-op. So we know that we have to limit fasting interval. We follow ASA criteria for that, 2 hours for fluid and 6 to 8 hours for solids. So that's not that new, but an emphasis to not allow this time period to increase, especially when cesarean sections are delayed for other emergent cases, which is often the case. Emphasis of non-particulate liquid of carbohydrate loading of 45 grams. And you can do this in many ways, from Gatorade to fruit juice. But this is an important aspect to decrease hypoglycemia and the metabolic response of fasting, as well as minimize the surgical stress aspect related to surgery. Now, the next 2 items are related to education, one with patient and breastfeeding, and then hemoglobin optimization. And the idea behind hemoglobin optimization is to screen for anemia, treat it preoperatively so that you can reduce post-operative anemia, which certainly impacts recovery and has other potential maternal morbidity associated with it. Now, I want to just focus a little bit about education, because for preoperative aspect, I believe this to be the most important aspect. Now, as I mentioned, the SOAP criteria goes through not only a recommendation, they talk about an action item specific, some comments around that, then the strength of recommendation and the levels of evidence. So strength of recommendation might be strong, moderate, or weak. Generally, for a lot of these criteria, they're on the moderate to weak side. And then the level of evidence is either class A, B, and C, depending on what sort of studies we have, either meta-analysis on the one end, all the way to just expert opinion. So for patient education, there is an action item to, at least at minimum, have a handout that's consistently providing information to all patients, and ideally before they show up for surgery the day before, so they have time to read the material. SOAP has videos that you can use if you want, and examples of educational material. And the whole idea behind education is to set expectations for mom and already start preparing her for what's ahead. And I think this is critical to decrease anxiety and improve the whole experience following cesarean delivery. Now at Stanford, we have a leaflet that everyone gets, Recovery After Cesarean Delivery one. It runs through a little bit about the anesthetic and frequently asked questions that we often get asked. And then the back side of this pamphlet is obviously more important than the initial introduction. And it goes through specific areas that we're already trying to get patients to focus in on, so they are aware of important areas for us: pain, skincare, eating and drinking, activity, breastfeeding, and other steps. And we do it in point form, so it's easily digestible information and gives them metrics by which they can expect to start recovering at certain points. So for example, for activity, we're expecting patients to start sitting up within 4 hours, that their bladder will be removed. At 8 hours, the actual expectation to walk around, and then to try and be walking at least 4 times a day. So that's the emphasis that we put on activity as an example. Now, this is an information package, but what's essential in when they're recovering is, are they meeting milestones and metrics, not only for the patient, but also for the providers to focus in on. So we have patient-facing documentation for the mom to look at. So it's very clear what she needs to achieve, and we break it up into the first 24 hours and the next day. We also have some educational videos so the patients are able to see the information on video form. And not only do we have this information for the mom in terms of milestones to get to, but also for the baby, because it's essential that the baby is also ready for discharge, because this can often delay the mom getting home. So they are required to recover and get processed in parallel. And it's critical that things like the hearing check, routine blood tests, etc., are done for the baby in a timely fashion to not delay recovery. All right, well, let's move to intraoperative. And as I mentioned, there's 9 items here. Again, each one is a topic in itself. Spinal hypotension is emphasized because this can increase nausea and vomiting. And we emphasize the importance of using vasopressors to minimize spinal hypotension, ideally as prophylactic phenylephrine infusions, and to limit the amount of fluid that patients get. Keep normothermia, both with fluid warming and keeping your operating rooms at 23 degrees, minimizing the use of uterotonics and the smallest, most effective dose. This is particularly important for oxytocin, but for also limiting secondary uterotonic drugs that have side effects, particularly nausea and vomiting. An emphasis to have at least 2 anti-nausea medications, because women are at high risk for nausea and vomiting after cesarean, to already initiate your multimodal analgesia. And here we're talking about good spinal analgesia. We also use 12 milligrams like Ruth does. We certainly do not use any less than 10 milligrams. And we already have our morphine and fentanyl in the spinal solution, the fentanyl for intra-op, but the morphine for post-op to really start to work. And then at the end of surgery, we actually give IV acetaminophen and IV ketorolac, so our non-steroidal and our paracetamol, to really start to initiate analgesia. Women are skin to skinning immediately, so babies are checked briefly and then is placed on the mom's chest for the rest of the surgery to start breastfeeding. And this golden hour is essential that the contact is begun, and bonding and improvements in breastfeeding can be shown with this approach. Now, we emphasize not using too much fluid, but unlike other models where enhanced recovery, where they really are stingy with how much fluid, we are aware that the average C-section loses about 1 liter. So we put it more towards 2 or 3 liters that you can give. And obviously, if you have bleeding, you should forget enhanced recovery principles and give the fluid that is required. So that's essential. And then delayed cord clamping is an ACOG recommendation, 30 to 60 minutes. Now, post-operatively, there's 11 elements, and these are clearly the most important area. And they follow the DREAMS principles. So you're going to think of one thing of setting post-operative protocols and items. It's drinking, eating, analgesia, mobilizing, and sleeping. And SOAP fulfills all these DREAMS principles plus a few more. And I'm going to run through a few of these that I think are the most important in the next few slides. So first, it's early oral intake. So this has to start in PACU already with ice chips, a little bit of water. You do not want to continue IV fluid. So we lock them off after 4 hours, and then we really encourage oral intake as best as a woman can tolerate. Early mobilization, SOAP gives examples of what we'd recommend. I've said at Stanford, we already are encouraging it at 4 hours. So 0 to 8 hours, SOAP says start hanging your feet over and make some attempts to get out of bed. between 8 and 24 hours, you should already be making attempts to ambulate. Do not wait the full 24 hours before ambulation attempts unless the patient is high risk, had a complicated cesarean delivery, perhaps on magnesium or other potential things that you're concerned with ambulation with. And again, we encourage lots of walking, 3 to 4 times a day if possible. Rest is essential, and one of the dreams principle of sleeping, I think women get so many interruptions, and this is something you really want to emphasize, that you cluster interventions. In other words, if a woman needs vital sign monitoring, that you can do it at the same time as giving your medications. Try and give your non-steroidal and your acetaminophen at the same time. Minimize alarms if possible. Balance feeding patients at the right time, etc. But you really want to make an effort to allow women to rest and recover. One aspect that is always lagging is removal of urinary catheter. What's different in our surgical model with cesarean delivery is women are getting spinals with intrathecal morphine that can delay recovery of the bladder muscles. So we think 4 to 12 hours is a reasonable time period. And you're going to have to just play around with this, because obviously if you take it out too soon, you do increase recatheterizations. And then breastfeeding support is essential. I already mentioned the golden hour within the first hour, but getting a woman up and running, especially after cesarean deliveries, elective ones, breastfeeding can be difficult, unlike women who've had prior labor or had vaginal delivery. So it's really important that this is addressed early to decrease delays and discharge delays because of breastfeeding issues. Now, Ruth already touched on multimodal analgesia and the importance of this. Obviously, this is an essential part of enhanced recovery. And the key points here is that you want good neuroaxial morphine at the beginning. We use 100 routinely, but we actually allow patients to either choose a lower dose, 50, if they feel they don't need as much pain relief, or 150 if they need more. So it's the low standard dose or the higher dose, which women select based on their preference. And then it's regular non-steroidals and acetaminophen around the clock. And it is critical to do this because you minimize how much opioids women use within the hospital. And the less you use in the hospital, the less likely you are to be prescribed opioids afterwards. And you've already heard from Ruth the problem with our opioid prescribing practice in the United States. We do recommend offering local anesthetic techniques as well, either as a rescue technique or routinely. All right, so I've gone on about all these interventions, but does it actually make a difference? Well, the first study that intimated that it may make a difference is from the UK, in Wren and colleagues, and they did 4 interventions, and you can see it marked with arrows 1, 2, 3, 4. The first one was just getting a multidisciplinary meeting together, and 2 was getting the educational leaflet material. And you can see the step up from a percentage of patients being discharged already there. 3 was a high caloric drink, so carbohydrate loading, and the 4th was warming. So you can already see it, you're on the flat part of the curve just after getting everyone together, discussing it and educating the patient. So it's more of a systems change that makes the bigger impact than individual items. One thing that's important to mention here is that this happened at a time when the UK was moving more and more towards discharging patients after 24 hours. You can see 25% are being discharged in day 1. So this is not a model that really reflects practice in the United States. But interestingly, despite this increasing effort to discharge patients early, they did not increase their readmission rates. So that's the first study that sort of intimated that might make a difference, enhanced recovery. But there's been several studies since, in fact, 12, and we did a systematic review and meta-analysis. And this is the best data we have at this point to show that it can make a difference. Firstly, length of stay can be reduced on average, 0.5 days. Time to mobilize reduced by 11 hours on average. Time to urinary catheter removal, 13 hours. This was the forgotten one, that women just had their catheter in for an exorbitant length of time without attempts to remove it. It usually was done at 24 hours before. Opioid consumption, significant reduction. This is because of improved multimodal analgesia, and even some evidence that it might save in cost without actually causing increased readmission rates that I showed earlier on the previous slide. Now, it does work. We know that. I think the evidence there is fairly strong. But one thing that is not known is which interventions make a difference. And I showed you all 25 interventions that SOAP recommends. I cannot tell you which ones of those actually are making a difference, but it's more the package, and very often just the act of getting together and thinking about it and creating something that's important. So we found with a systematic review 42 interventions that have been described in the package of enhanced recovery and 90 outcome measures. So there are so many outcome measures of measuring success, which is a big problem. So for the last part of the talk, I want to talk about recovery metrics that you can use to see if someone is doing good enhanced recovery. And I mentioned the 90 outcome measures, so we really thought it's important to sit down and try and define more core outcome measures that you can use to enhance. Now, this has not been published. This is a group of experts that got around the table using Delphi methodology, using all previously used outcome measures to measure enhanced recovery. And this is what we've come up with. And it'll soon be published, and it's something that you can at least use as a starting point to see, are we able to use these measures to be able to see what sort of job we're doing and adjust our protocols as needed. So there's general measures like length of stay. Remember, length of stay is impacted by a lot of factors. In the United States, women can stay up to 5 days after a cesarean delivery. So it's more about being ready to leave if women want to leave. And very often women who are having their second or third babies and know, all that there is to know are ready to leave a lot quicker. So length of stay is an important metric, especially the variability in the length of stay, even if the mean doesn't change much. Bundle compliance, obviously an important thing. Are you actually doing what you say you're doing with your enhanced recovery? And then a lot of maternal outcomes like satisfaction, which has already been mentioned as important, the satisfaction with analgesia specifically, opioid use, either milligram equivalents or the percentage that are using opioids or requiring them, postoperative nausea and vomiting incidences, readmission rates, reattendance rates, in other words, unplanned visits of women rather than being readmitted, and then a global score, which I'll talk a little bit more about, the quality of recovery 10 score. There's some process metrics that are important, like are you minimizing how long women are fasting for prior to their surgery? How quickly are they taking liquids and solids? Mobilization, urinary catheter removal, as we discussed, are important metrics, and then breastfeeding at the time, so a neonatal measure. So this is what we came up with. Obviously, it's not an absolute, but these are important metrics to use. I mentioned the quality of recovery score. Pervez Sultan is the brainchild behind this. We've done a number of studies validating this. And what's nice about it is it gives you more of a global measure of how a woman is doing. It focuses on 10 questions, both pain and side effects, so pain, nausea and vomiting, dizziness and shivering, and then a lot of the other important aspects about how a woman is actually managing, like has she been comfortable, ability to mobilize, being able to look after a baby without assistance, feeding the baby, personal hygiene, as well as feeding in control. And this is something that is free to use, and if it's easier than doing individual metrics, as I showed earlier. So that's the easy part. So it does work, I think, and there are ways of measuring success, but getting it up and running is the difficult part. And very, very briefly, this is a village effort. So you cannot do this alone. So as an anesthesiologist, if you want to change it, you are not going to be successful. You may change one or two items in the protocol list, but to really make a difference, you need everyone on board. And I've listed some of the people involved, the key players involved in this effort, but it really is essentially a group effort. And then you have to get change, and change can always be difficult. I think the things that we've learned along the way is there are two patients. You have to involve the neonatal team, neonatologists, pediatricians, and everyone else involved early, because you are processing two patients in parallel. And if the baby's not ready, then the mom is not ready to leave. You need physician and nursing champions. Physicians cannot do this without nursing buy-in. You need hospital buy-in. And we find that you need information technology support, as well as help from quality assurance, because you have to be looking at these metrics and adjusting accordingly. But Zev Kane, when he initially proposed enhanced recovery or perioperative surgical home, he gave me the slide, which I think it says it all. You think that it's difficult to change because of infrastructure issues and technology, but the reality is really it's just a culture change, and getting everyone on board is the most difficult part and the most essential part. So this is what we did when we started. Lots of post-it notes, lots of meetings, lots of metrics being looked at, evaluated, different ways of determining it, milestones, next steps, etc. So it was a long process with lots of key stakeholders involved. And the key was that we set up metrics that we could evaluate near real time with dashboards to see what sort of job we were doing, and then addressing problems. Because it's one thing, the easy part is just creating a protocol and putting it in place. The more difficult part is there going to be compliance, and are you actually still making a difference? So this is essential, that you must have some way of doing ongoing metrics, and ideally real time, because it should highlight women that are not doing well with recovery, so they can get extra interventions to get them out of the hospital sooner. All right, so I hope I've given you some insight into how to at least address enhanced recovery after cesarean delivery. I think it's an extremely important aspect of care. And I'm happy to take questions and go from there.
Thank you, Brandon. You have so many questions in Q&A box. You may answer it now by writing, or maybe you answer after we are doing the Q&A session. Since our colleagues from Colombia could not join us, if you allow Ruth and Brandon, I want to make like a progress report on, because of you, Ruth, that on February 2019, you give the lecture of this, and then you encourage me to promote this beautiful pathway to our colleagues in Indonesia. And I started on March that year as well. If you allow me, I have some slide to show you. It's okay, Brandon? Also?
Yeah,
okay.
that'll be great.
We'll do quickly. My question is, what are we doing wrong in Indonesia, and not all over the world? Because we found that after I start on March 2019, I do it as Brandon say. I just do it by myself, and only 3 obstetricians join with me with this pathway, and then it is not work. At least I do it 1 year and not working. So what I do after that, I contact with the hospital management, and it is getting better and better, because we can cover also the nursing care, the midwives, and maybe pediatrician. On August 2020, I started the first national webinar on ERAX, and also I did it on 2020 December. Till now, maybe I already did like 30 times, 30 times webinar with ERAX, with the small group, big group, small hospital, group hospital. And I found top-down message, top-down policy is better, but still not enough, because there is so many barrier in anesthesiologists, obstetrician, pediatrician, nurses, nutrition, and last but not least is hospital management. And I found this article, very interesting article, that the grandfather of ERAS is Professor Henry Kellett. He said that enhanced post-operative recovery, good from afar, but far from good. He mentioned about so many lack of leadership, lack of knowledge, and cultural variation in practice. As Brendan said, that in our we are usually do as an individual clinician. So if it is a standardized protocol, then sometimes we cannot comply. Not just anesthesiologists, but also obstetrician. Because so many elements that we should comply, then it is make more problem. Not yet interdisciplinary disagreement also happen. So this is more and more difficult. Although now, Ruth, I just want to say you that almost all hospital in Indonesia, small hospital, rural hospital, urban hospital, small, big hospital, give this pathway as their program. But thank you for that, because I start from this. If you see that the name of Brendan Carvalho and Ruth Landau is mentioned there, so we are lucky the participant that we have the two of them is already here to give more enlightenment of the ERAX. And then I want to say that this in pre-admission, we don't do it well, because it takes time to teach the patient educator. Then more difficult also for lactation and breastfeeding preparation and education. And the obstetrician, although it's already mentioned in WHO that hemoglobin should be increased, they not doing well pre-operatively. And it's funny that sometimes in one hospital, just because they give a non-particulate liquor carbohydrate loading 2 hours before surgery, they say it is ERAX. It's happened in Indonesia. Only one element, he said that declare that they do it ERAX. This the what we doing wrong. Also this, yeah, so many people ask you, Ruth, about the dose of local anesthetic you give, because I propose very low dose, only a half of your dose. So why? Because Indonesian woman is not that high like in United States. And the second, I do combine with the fentanyl. I give 6.5 bupivacaine and 25 micro of fentanyl, 100 micro of morphine, and then I do Trendelenburg the patient, like 10 to 20 degree. So it makes the block is high, but the dose make the blood pressure is not going down. So we have to benefit for low dose with Trendelenburg. So I make a mistake also. I promote this to everybody. This is not good actually. I found now after 3 years promoting that let the people do that they will like, but do all the things, the element that already mentioned in SOAP recommendation, and so on and so on. And unluckily, the after effect is so high in Indonesia. Everybody euphoria, as I mentioned. This is if it is like you sell the property you promote the price of the pathway. It's not good, but it's happened. Then the anesthesiologist, obstetrician, business as usual. Do not do the protocol, comply with the protocol very much. And they finally say that it is a new treatment, new modalities. So why don't we increase the tariff? It is not the goal of ERAC. Because the ERAC goal is reduce cost and length of stay. It's not anesthesiologist only, the obstetrician and the hospital also. So it is not so good. We're doing wrong. This is also already mentioned with Brandon that the first treatment, the first choice is triad of analgesia, itimorphine, NS8, and paracetamol. And because it mentioned in your recommendation and also mentioned in prospect guidelines. A real success story actually already mentioned also with Brandon that we have to at least do 24 hours check following the surgery to make sure that the patient is happy with our treatment. If be pain or nausea and vomiting, dizziness, shivering, and so on. So I think that's all I want to show you. Then we can start our discussion. Do you have anything to say before we do the discussion, Ruth or Brandon?
First of all, I would like to thank you for bringing us together and talking about this important topic, because as we all know that cesarean section is such a common surgery, and we put everything in the same bag, but there's so many different circumstances that lead to the cesarean section. Those who know they're going to have it and those who don't know they're going to have it. For some, it's the first time. For some, it's the third time. Some have had other surgeries. And so I think that's what we're seeing now. It's almost like the phenomenon of the pendulum that swings. We like in general to have standards. We like to have a recipe that works for everyone. And I think, we might have given too much and kept women in bed for a long time. Now we're going down with the intention of getting women out of bed fast and getting them out of the hospital fast. But I think that what's going to happen is that some women qualify and will have a very fast recovery, which is enhanced and fast track. And for others, it's not reasonable, or it's not practical, and it's not, I think it's too ambitious. So I think we're coming back to the situation where we have to remember what brought the patient to the operating room. Is it the simple C-section? Is it the complicated C-section? Who is the surgeon? We're not talking about this enough, but we have surgeons. The patient, it's a 20-minute procedure, and women barely felt anything. So I'm seeing it from the questions in the chat. A lot of people are asking about the dose, and I realized that 12 milligram must be perceived as a high dose, but we really also need it because, and I put it in one of the answers I typed, because our obstetricians do exteriorize the uterus, not all of them, but most of them do. And we are in an academic setting where the obstetricians are training. So just like we have our trainees, they have their trainees, and our C-sections are not necessarily that fast. I didn't mention, we didn't talk about it today, but a lot of our patients are morbidly obese. Okay. And a lot of our patients have a very low tolerance for discomfort. So I think it's impossible to create an algorithm that will spit out the number, how many milligram of hyperbaric bupivacaine we should give patients. But I think we know to recognize who might be a patient who will, have a simple cesarean section versus those that might have a more complicated one. And it's okay to change the dose. I do that all the time. I give a bit more, a bit less. I have a cocktail, but I tailor when I see the patient, the circumstance, who the surgeon is. And I think I spoke about it when I was in Indonesia a couple of years ago. There's another thing I look at, which is how much the response to the numbing at the skin. When we do the numbing, we see certain patients jump off the table and others don't seem to mind the local anesthesia infiltration. We had actually published a study a couple of years ago where we evaluated the pain medication consumption after the C-section based on how much pain patients reported experiencing during the numbing, and it was correlated. So sometimes you can see by the behavior of the patient before you did the spinal. And I always tell my trainees that based on how much the patient jumps or doesn't jump, I may actually modify the dose. So that requires having the ability to change a little bit. So we give 12. I very rarely give less. And the fentanyl is indispensable. The morphine is for the postoperative pain, and the fentanyl is for the intraoperative visceral and pulling and tugging. And I wasn't sure whether it is available everywhere. A lot of people ask me why we give so much bupivacaine. If you have the fentanyl, you can probably reduce the dose, but if you don't, you need a level.
Yeah, we have fentanyl here in Indonesia.
Yeah,
Okay,
if I
Brandon.
can add, if I can add a little bit. So we similarly use 12 milligrams. This is based on dose finding studies that we did at Stanford. I think it really depends on your surgeons and how quick they are, and as Ruth mentioned, externalization. Spinal hypertension used to be a big problem, and that's why we really try to reduce our dose. I think with phenylephrine infusions or boluses, we have eliminated that as a problem. So reducing your spinal dose just to eliminate hypotension is no longer necessary. So I would strongly encourage, especially in light of what Ruth showed, that a lot of women are experiencing pain during surgery, that you really don't want to underdose a woman. So if we ever use less than 10 milligrams, it's part of a combined spinal epidural technique. So it's 12 milligrams routinely, and if we're going to reduce it for whatever reason, then it's we have an epidural to help us out.
How about the rescue of if the patient is hypotensive because of your dose? Usually
so we routinely run phenylephrine infusion with a co-load. So we're giving fluid, a liter of fluid with a under pressure. So you use a arterial line bag to squeeze the fluid in, and you give it at the exact time you're giving the spinal medication. So classic co-loading, and then run a phenylephrine infusion starting at 0.5 mics per kilogram per minute. And this essentially eliminates spinal hypertension. You might get it 5 to 10% of the time, and it's easily treatable. So that's the key. If you're not going to be giving prophylactic medication as an infusion, then watch that heart rate incredibly carefully. The second the heart rate increases, you'll never overcompensate with a heart rate increase. The woman needs a alpha agonist, a SVR increaser. So she has to, so you can already start dosing it even before the blood pressure is back. You can start giving boluses of phenylephrine.
Okay. Yeah, the other important thing that in Indonesia is not available yet, phenylephrine. But in this meeting, the Fresenius Kabi have launched this phenylephrine. Hopefully after this, our colleagues that don't like the low dose can do it as a regular dose, but with the preparation of phenylephrine drip infusion.
I mean, there's nothing magical about phenylephrine as long as you are using an alpha agonist, because the primary driver behind spinal hypertension is a reduction in systemic vascular resistance. So ephedrine is not a good drug because it's mainly beta. You really want alpha. So you can use metaraminol, norepinephrine, just something that has alpha qualities that works quickly, because what makes phenylephrine great is it works quickly, and it's addressing the primary source of spinal hypertension.
Do you want to add something, Ruth?
I wanted to ask you, what is it that you do have? And And again, we have been using phenylephrine for a long time. I typed it in one of the questions, which is why we don't worry as much about hypotension. I mean, we care, but we don't worry because with the phenylephrine, we're preventing the blood pressure drop. And we do give some fluid. Brendan mentioned, you want judicious, but at the same time, we don't keep our patients dry unless they are they have a cardiac comorbidity or they're preeclamptic, and we worry about pulmonary edema. But we do tend to give them easily 2 liters of fluid during the surgery. I was sure someone would ask me about tilting the patient to prevent or manage hypotension. No one has asked me, so I will preempt the question, because my group has published a paper saying that there is no need to tilt patients for left uterine displacement. And I think with that paper, we have created a monster, because the study was a superbly conducted randomized controlled trial in 100 patients that were all healthy with a planned cesarean section. None of them were preeclamptic, none of them were morbidly obese. And that's not the majority of our patients. And the interpretation of the result was that we don't need to tilt anymore, because with the phenylephrine that we were giving anyway to everyone, and yes, the group that was randomized to not being tilted anymore did require a little bit more phenylephrine to maintain the blood pressure, but without it impacting on neonatal outcomes. It was perceived that we don't need to tilt, and our obstetricians loved not having the patients tilted anymore. So I'm now, again, this is the phenomenon of the pendulum. I've spent the last 6 months saying that we're tilting again whenever we feel that the patient needs the tilt. It's actually quite remarkable. You see it right away. If you didn't tilt the patient, there's not enough phenylephrine on the planet to maintain adequate perfusion for the mom and the baby, by the way. And so I keep them tilted. I actually tilt them, and I progressively now untilt if the patients tolerate it, rather than doing the other way around, where we had stopped tilting, and when we had profound hypotension, we would suddenly remember that there's this thing called the tilt that we could apply to patients to bring back the blood pressure. So that's something else. I don't know what your practice is, if you're tilting, not tilting, but it does work in the subset of patients who do have supine aggravated by the spinal hypotension.
Yeah, I'm thinking almost all of anesthesiologists in Indonesia do not do the tilting. The second is we only have ephedrine for hypotension. So yeah, hopefully with phenylephrine, the dose of bupivacaine can be increased without afraid about hypotension. Yes.
So you said that you might be getting it, that you're hoping that it will become available, or
yes,
an alpha agent. That's fantastic. That will change your practice. You will be able to maybe, we call it judicious or Goldilocks, not too little, not too much, just right. The amount of bupivacaine should be not too low. It should be just right. And interestingly, I don't know if you are aware, but we have our colleagues from Brazil who do a lot of cesarean sections in some of the urban, Sao Paulo in particular, and their surgeons are very, very quick. They do the cesarean sections in 30 minutes. And Monica Ciolis, we know her well. I was impressed to see, actually shocked to see, that she uses 15 milligram of hyperbaric bupivacaine when I would have expected her to use less, because the surgeons are so fast. But she said she uses that, on the contrary, as a fast protocol, because it kicks in fast. It allows them to start faster. They put the patients in the recovery, they recover. And actually that is her ERAS protocol with 15 milligram of hyperbaric bupivacaine. So I think it really depends on the environment. I think even with quick surgeons, places have adopted the higher dose, but they of course have the prevention of the hypotension with a vasoactive agent. I think it's fascinating conversations to see what is needed, what is available, and what makes what makes it work in in an individual institution compared to another.
Yeah, it's very.
Yeah.
Do
So if
you
I can
have
say,
Yeah, yes.
I'm so happy to hear that Ruth's gone back to the tilt, because she knows I was a big critic of not tilting.
I never stopped between you and me.
Yeah, it's critical in some patients, not all, but and you know, the study was done with phenylephrine infusions. It wasn't a real world example of what could happen without the tilt. So I'm really, really glad. I wanted to address just one. There's been a few questions related to this.
Yes, please.
In terms of tap blocks or enhanced recovery, etc., or wound infusions. And Ruth can obviously speak up, but if you give intrathecal morphine 100 to 150 and around the clock NSAIDs and acetaminophen. And by the way, we give intravenous acetaminophen. You can just as easily give oral. We only do the first dose as intravenous. So there's no advantage of IV versus oral. It's purely for ease of use. We can do it intraoperatively. If the patient's nauseated, they won't vomit it out, etc. But if you do that combination, most patients do really well. But, you know, and your pain scores are like 3 to 4 out of 10, but 2/3 will still need some breakthrough opioids. So what we've done with our opioid is we've really tried to prescribe as little as possible. So we actually only do half a tablet, and they get the other half an hour later if they're still in pain. If they are increasing use of opioids, we go in and we do offer rescue tap blocks or some other technique like gabapentin to try and stop them using increasing opioids, because that's the problem. You don't just want to keep using more opioids. In terms of on-cues adding benefits, it's certainly tap blocks and on-cue catheters, or sorry, any local wound catheters do improve analgesia if you don't use intrathecal morphine. There's very good data for that. But if you use intrathecal morphine, the data is a little weaker. And we feel because of the weak data, tap blocks are not necessary routinely. So we just use them for rescue in women who are struggling. And for on-cue catheters, we thought it would make a difference. And we actually did a whole programmatic change to offering it routinely. And our data does not suggest it made a difference. So we still went back to using it in select patients, anyone you're worried about for whatever reason. So someone who can't take NSAID, someone who's got preoperative pain, highly anxious woman, or someone who has pre-existing pain or requiring opioids, then we do use routinely local wound infiltration.
Yeah, I agree with you, because we do in our house, private hospital, the routine 24 hours survey from the patient by Google form. We know that combination of morphine intrathecally plus paracetamol and NSAID around the clock, it's worked very well. So no need to give more things to make it more difficult, I think, in my opinion. How about you, Ruth?
Sorry, I was checking the question. Can you just ask your question? I was looking at the chat.
Okay. No, it is not a question. It's just need a comment that I agree with Brandon that by literature and by my own experience, because we do survey after 24 hours, and patient with the Google form found that the morphine plus paracetamol and NSAID is work very well. No need to add something that maybe more
it does work great. And I saw in the comments someone was asking about why we give fentanyl and morphine. Fentanyl is really for the intraoperative portion, and then the morphine takes a little bit longer to kick in, but will last, depends, 18 to 24 hours. And by that time, the patients are able to take by mouth the NSAID and the paracetamol, which they should be taking around the clock. And I can tell you it works well on our patients, because we were not doing it as well before. And we did a drastic change in our order set in 2019. And we looked at the amounts of rescue opioids that patients were taking before. We made it mandatory that they take their Tylenol and the NSAID before they're allowed to take the oxy. I always said as a joke that patients can't take the desserts before they ate their fish and the broccoli. So the paracetamol and the NSAID is fish and broccoli. And if you finished all that and you're still hungry, you can get the dessert, or they can take the oxycodone. But my point is that we've seen a substantial reduction in two things. The number of patients who even need any oxycodone has increased. So in other words, there are many women now who don't take any opioid at all. And amongst those who do take opioids, the total dose of opioids during the hospital stay has reduced dramatically. And I've always said that people know that I had a C-section 15 years ago. You know Mia, she's 15 now. I had 0 opioids after my C-section, and I don't think I'm a hero. I just took my Tylenol and my ibuprofen for a week, and I think I'm good. I don't think I have any trauma from my C-section. I think I'm performing okay. I don't think I have any depression that is residual. So I'm just saying it is doable, it's feasible, but the morphine in the spinal is necessary for the first 24 hours, and then the cruise control on the non-opioids.
Yeah. The other thing, I just want to add one thing to what Ruth said is, enhanced recovery, the whole idea is to standardize care, give everyone the same care, and do the best care possible. And it's great, and the vast majority of patients do great, but there are 10 to 20% of patients who struggle. So it's absolutely what you should do, applying a blanket enhanced recovery to everyone. But don't forget, still personalized care, still make sure some women are not doing well, that they get addressed. So you never will get everyone happy. And there's a lot of good studies to show that, that 10 to 20% of patients are the ones that no matter what you do, you could probably give everything. From gabapentin to local to everything, and there's still problems. So,
luckily we only have. Actually, it's unluckily we only have pandemic of COVID-19. We don't have pandemic of oxycodone in Indonesia. Not like in Europe or in the United States. Not that popular oxycodone in Indonesia.
Yeah, it's interesting. We've reduced our opioid use remarkably over the years I've been at Stanford. Yeah. And I'll tell you that it hasn't just been through good analgesics like routine acetaminophen and intrathecal morphine and nonsteroidals, but it's through good prescribing practices. I actually still believe that makes the biggest difference. So educating a woman early, making them realize pain of 0 is not what we're aiming at. We're just trying to prevent severe pain, to understand it's part of the process, and to make sure the nurses are fully educated and aware of how to prescribe medication. And we found that halving the medication and coming back an hour later, which in America, nurses have to report pain reduction after prescribing. Just that intervention alone halved the amount of opioids we used, even though the women were getting the same amount of opioids prescribed. So prescribing practices are essential.
Do you have a protocolized for breakthrough pain postoperatively, Ruth? Or just
yes, definitely. So what Brendan was saying is exactly that. Actually, the order set that we changed when I mentioned in 2019, it was really semantic changes. In other words, the nurses, as soon as the patient was complaining of pain, would bring the opioid. And what we told them is the Tylenol and the NSAID needs to be given first. And if despite that the patient has pain, then they can get the oxycodone. And then another thing that used to happen in the United States, which Brendan mentions, is that there was this notion that if pain was severe, so a pain score of 7, more than 7, then automatically the oxycodone was written for 2 tablets, which is 10 milligram. And if it was 6/10, patients were prescribed to receive 1 tablet. We've changed that because there's actually no pharmacological basis, pharmacokinetic basis, or pharmacodynamic basis to suspect that if a patient has more pain, they need 2 tablets. In fact, some studies suggest the opposite, that if you're in a lot of pain, you're going to upregulate your mu-opioid receptors, and a smaller dose might be sufficient. So asking the pain score is already a very bad surrogate for the pain that is perceived by the patient. But managing the pain based on the score that the patient is giving is also really bad. So patients receive 5 milligram if they want, but we've told them that it's an opioid and it does cross the breast milk, and that there are recommendations for them not to take more than 5 tablets in 24 hours because it has been demonstrated that babies get sedated, particularly in mothers that have taken more than 5 tablets. So when we tell them that, no one wants to drug the baby, and women understand they've had a baby, it's the beginning of a tougher life, and they need to be a little bit tougher. The other thing I wanted to come back to, it was a very good question in the chat box, was how do we explain to women what it is that they're going to feel during C-section? How do we tell them pulling, tugging? I don't have a superb answer. The first thing I wanted to say, it's not just in low and middle income countries that it's difficult to explain. The most educated women in our institution also ask these questions, and it's very difficult to explain. But what I do tell them is that there's a difference between the blood pressure cuff going on and off, which is a sensation that they feel, and this being painful. I said, you might not like it. It might be uncomfortable, but that's not pain, that's pressure. And it's the same explanation I give to women with the epidural during labor. I tell them you'll feel pressure with the contraction, but it won't be painful. And if it is painful, we can give you more. So I think it's the same thing. I try to say it with a little bit of a sense of humor and tell them, you're having a baby. Did you expect it would be with no sensation? We're not giving you a no sensation delivery. You will feel pressure, you will feel pulling, you will feel the obstetricians shaking you. Sometimes we have obstetricians that really move the table. And if they are, and I can see it behind the curtain, I tell them, I'm really sorry they're shaking you because they're trying to help baby come out. I think it's important to tell them that you're having a baby, you're going to feel things. If it's too uncomfortable, we can give you medication. And as I said, I am convinced that sometimes we give medication when, if we ask the patient might have said there's no need, and vice versa. And this is a project that we're starting now, is to try and correlate what happened in the operating room with what patients tell us the next day. So we're going to start a study where we're asking women to tell us if they felt pain, if they felt we managed it well, if they would have, and I'm sure there's certain patients who think we didn't give them anything when we did, and the other way around. We'll be able to look at that. It's a very difficult situation, and I think no anesthesiologist wants to be in a situation where the block has failed and nothing was done, or the things were not in an appropriate manner. So the failure is not in the block. I always say the failure is in our lack of rescuing the insufficient anesthetic and leaving a patient unheard and hurt. I think that's the failure. The failure is not in the block not providing a sufficient level. That can happen, but we need to address that. And if we weren't able to address it well enough, definitely we need to talk about it. And I think that's the difficult conversation. Some people don't like to admit that it hurts, or going to the patient and say, I'm really sorry, I think that you were in pain, is not an easy conversation to have. But I think it's a necessary one. And I think it's also important to, as I mentioned, to document, because often these women come back, they have another C-section, and they might be terrified because they're dreading to have the same thing happen again. So first of all, telling them that we recognize it happened, that we're putting a note in their chart, that we will talk to them beforehand, that we'll do our best for it not to happen, that we will check the block, and if it doesn't work well enough, they should tell us. I think already things that are going to help women.
Yeah, The things that I found in postoperatively is we already order that the NS8 and acetaminophen is around the clock, but practically nurse forgot to give it. Patient already in pain. Actually, the pain is come not from the pain itself, because the medicine that should be given around the clock is not at that the exact time. That's make a problem also, because lack of nurses as maybe everywhere, but that happen in our institution. Do you want to have any other
So
comment?
do you
Yes.
have the ability, to do an audit and discuss
Yes.
the non-compliance with the nurses?
Yes.
Are they
yes.
receptive to the comment of lack of compliance?
Yeah, luckily we have the management hospital is very good. They're taking care of this. Not us to just we just give data, then the management do the things that they should do. They teach again the nurse how to why should give around the clock medicine and so on. But it is still happen again and again and again. But yeah, we try to do it more frequent to give nurse that their task is very important in Iraq, not just anesthesiologist and obstetrician. Brandon, do you have any comment?
No, I agree. And that's why I said the easy part is come up with a protocol, hand it out and say, we are doing enhanced recovery. The reality is, how have you implemented it? Are you using it, measuring it? And I can tell you, terrible. I mean, at Stanford, like urine catheter removals was just a joke when we first audited it after enhanced recovery. It was terrible. I mean, close to 24 hours. And like, that's not enhanced recovery. So we again, nurses have to be educated, help shown that the data is suggesting they're not doing it, practice changes, keep looking, look at for compliance, collect data, circle back. It's really not easy. I wanted to mention just one thing just before, because there's been a few questions related to it, is about alternatives to intrathecal morphine, either because it's not available or other reasons. So what makes intrathecal morphine fantastic is, firstly, it's cheap and often widely available, but it is the least lipophilic, so it has the longest duration after a single dose. So there's no other equivalent to intrathecal morphine in terms of single administration and duration of action. The side effects are often dose related, so you just got to be careful of how much you give. If you don't have it, pethidine is too lipophilic, so it's going to only probably give you, 6, maybe 8 hours of pain relief afterwards. Fentanyl, again, is, even with big doses, it's maybe 4 hours. Sufentanil is the same problem. Dilaudid, or dihydromorphine, does have longer duration of action. So that is something you could consider using, not quite as long as morphine if you have it available. And then obviously in the UK, diamorphine, heroin that they use is clearly as good as morphine, because it gets broken down to morphine, and so it actually works like that. But it's often not available. But if it was available, I certainly would use that as an alternative.
We have pethidine here in Indonesia, and morphine and fentanyl. So sometimes that the morphine is empty in the whole country. I encourage my colleagues to give pethidine intrathecally to make sure that they can do in as a anesthetic agent, and also for analgesic postoperatively. Yeah, it's like 6 to 8 hours. It's very good also.
One of the resistance to using intrathecal morphine has always been respiratory depression concerns. And there's a SOAP consensus statement, I don't know if anyone's aware of, but it is a really important statement because it breaks down administration to different doses, so either 50 or 100 or 150. But if you use 50 micrograms, you do not need to add any additional monitoring. The risk is viewed as low enough that just standard surgical monitoring after cesarean is sufficient. And 50 micrograms does give you decent analgesia. There's even a study comparing 50, 100, 150 showing minimal differences when you use it as part of multimodal. Obviously, if you're not using multimodal, you need to give bigger doses. So don't let that be a reason to not use intrathecal morphine, and just select the smaller doses to minimize respiratory depression and monitoring concerns.
Thank you. For the take-home message for our colleagues, audience, do you have anything to give, Ruth and Brandon? Start with lady first.
First of all, I want to say I am beyond impressed with the audience. There's 730 participants. I don't think we have that much of an impact in our presentations in North America. So my first thing is thank you to you for your ability to gather so many people around important topics. I want also to thank you for your vision of having people from around the world. I know you mentioned 46 countries are represented in the 730 people. I'm blown away. I'm blown away by your ability to make a change when there's no drugs, there's no supplies, there's no. And I'm also looking at this gallery of portraits and thinking this is the coolest Zoom webinar I've seen. This is fantastic. But I know that's not what you asked me. You asked me my final words. My final words is going to be simple. Listen to your patients before you go to the operating room. If it's not their first C-section, ask them, how did it go last time? And try to make it as good as it was last time or better if it wasn't great. And we are mixologists. That's why I said cocktail. And even though we love standards, we love blankets, and people who know me, I've printed everywhere visual didactic, visual tactics in the operating room, so people know what the standard is. And I'm always varying around it. So there's a standard. I always tell them, if I have a stroke in the middle of the night and I'm not able to be there, this is what I want you to give, because with that, the patient is safe. But then I tailor it to the patient. The patient jumped off the bed. The patient is anxious. The patient is short, tall, big, small. The surgeon is slow. The surgeon is great. It's 5 o'clock in the morning. I'm tired and I might not have the same ability to hold the patient's hand. I'm serious. Sometimes you really add on to it things that are unique. So Brendan mentioned you individualize and you tailor. So you need your standard that you know well, that you're comfortable with. Listen to your patient. And if they're not comfortable, talk to them, ask them, what do they want? And I always say my voice is worth a lot of milligram of midazolam. I don't often give midazolam. I talk to my patient. I hold their hand. I still do it with the gloves, the mask, and everything. But we should be nice to our patients. I think that's my final message. Be nice.
Be nice. Listen to the patient.
Yes.
Brendan?
So, well, firstly, thank you for the invitation, and I agree with Ruth. It's amazing participation, number of questions, and it's inspiring. And to you, Cecilia, over the years, you've just made such an amazing contribution towards obstetric anesthesia education, and I really thank you for that, and thank you for our involvement. To follow on from what Ruth said, listen to your patients. I completely agree, and listen to your obstetricians and everyone around you. Communication is key. And if you're going to put enhanced recovery into play, you need everyone. You can't go alone on this. So I think that is essential, that you as a team get together and you try and do the best thing for the patient. And I think what enhanced recovery has taught us is maybe we've been too obsessed with pain scores and perhaps opioid consumption. And there's a bigger picture here. And it's getting patients safely home, recovering well, having a good experience. So I think we need to shift that emphasis on pain scores towards a more global recovery. And I think that's key, if I have one take-home message. And while I'm all for standardization of care, like Ruth said, don't forget there's individuals at the end of all of these. So we can't be that definitive with anything. And even the best protocol in the world still has women that struggle, and they definitely need additional attention.
Thank you, both of you. We are very happy to have you both. I think also the participants, because the number is always increasing, and we left 13 question unanswered. It means that everybody eager to have this lectures. So thank you very much, Brandon. Thank you very much, Prof. Landau. Hopefully we meet in Jakarta someday, next year, who knows? Because now if you come to Jakarta, then you have to quarantine like 5 days. Nobody like it. So I'm waiting until no quarantine, then